Premature rupture of membranes. Premature rupture of membranes, PROM, is the rupture of gestational membranes prior to the onset of labor. When membrane rupture occurs before 37 weeks of gestation, it is referred to as preterm PROM, PPROM. This activity reviews the evaluation and management of premature rupture of membranes and highlights the role of the interprofessional team in identifying and treating this condition. Introduction. Prelabor rupture of membranes, PROM, is defined as rupture of membranes before the onset of labor. When membrane rupture occurs before labor and before 37 weeks of gestation, it is referred to as preterm PROM, PPROM. There is a wide array of mechanisms that cause prelabor rupture of membranes. It can result from a physiologic weakening of the membranes, combined with the forces caused by uterine contractions. Intraamniotic infection is commonly associated with PPROM. The major risk factors for PPROM include a history of PPROM, short cervical length, second or third trimester vaginal bleeding, uterine overdistension, nutritional deficiencies of copper and ascorbic acid, connective tissue disorders, low body mass index, low socioeconomic status, cigarette smoking, and illicit drug use. Despite a variety of etiologies, often there is no obvious cause that is identified in a patient who presents with PROM. At term, PROM complicates approximately 8% of pregnancies. Preterm PROM complicates about 1% of deliveries overall, and it is twofold more common in African Americans. Rupture of membranes results from a variety of factors that ultimately lead to accelerated membrane weakening. This is caused by an increase in local cytokines, an imbalance in the interaction between matrix metalloproteinases and tissue inhibitors of matrix metalloproteinases, increased collagenase and protease activity, and other factors that can cause increased intrauterine pressure. A thorough history should be performed for all patients complaining of leakage of fluid. This includes a history of present illness, obstetrical history, gynecologic history, medical history, surgical history, social history, and family history. When obtaining the history of present illness, it is important to inquire about contractions, fetal movement, time of possible rupture, amount of fluid, color and odor of fluid, vaginal bleeding, pain, recent sexual encounters, recent trauma, and recent physical activity. Physical exam should be performed in a way that minimizes the risk of infection. A sterile speculum exam should always be performed. During the speculum exam, patients should be inspected for any signs of cervicitis, umbilical cord prolapse, vaginal bleeding, or fetal prolapse. Digital exam should be avoided unless delivery appears imminent or patient appears to be in active labor. The cervix should be examined during sterile speculum exam to assess cervical dilatation and effacement. If necessary, culture should be obtained at the time of sterile speculum exam. Visualization of amniotic fluid passing from the cervical canal and pooling in the vagina will typically confirm a diagnosis of membrane rupture. When examining amniotic fluid under a microscope, arborization, or ferning, will be identified. A pH test can be performed of vaginal fluid. Amniotic fluid typically has a pH of 7.1 to 7.3, while normal vaginal secretions have a pH of 4.5 to 6.0. Causes of false positive pH tests include presence of blood or semen, alkaline antiseptics, or bacterial vaginosis. False negative results may occur with prolonged rupture of membranes. It can sometimes be difficult to definitively diagnose PROM based on the above evaluation. There are additional tests that may aid in the diagnosis. Ultrasound should be performed to evaluate amniotic fluid index. Fetal fibronectin is a sensitive but nonspecific test for rupture of membranes. In addition, there are several commercially available tests for amniotic proteins which report high sensitivity for diagnosis of rupture of membranes, too. If after a full evaluation the diagnosis still remains unclear, ultrasound-guided installation of indigo carmine dye can be used to determine if membrane rupture has occurred by evaluating if the dyed fluid has passed through the vagina, using a tampon or pad. If the tampon or pad is stained blue from the dye, rupture of membranes is confirmed. Differential diagnosis: Crohn's disease, lower urinary tract infection, rectovaginal fistula. urinary incontinence, urogenital tract trauma or surgery, vaginal douches, vaginitis, vesicovaginal fistula. Go to. Complications. Infection risk in fetus and mother. Perinatal mortality. Respiratory distress syndrome in infant. Intraventricular hemorrhage. Fetal lung hypoplasia. Risk for cesarean section delivery.